We recently published a paper in the BMC Geriatrics around quality indicators for older persons in acute care. This work was done quite a long time ago. It took us a long time to get to the point of publishing it, but it still seems fresh and relevant as you read the paper now. So hopefully you'll be taking an opportunity to have a look at this if you're interested. So this is the header for the paper that's in the journal. If anyone wants to get the URL exactly, I'm happy to share it after the meeting. So Melinda Martin-Khan wrote the paper. Quite a lot of other people were involved in the work, and it kind of kicked off back in before 2010, but it took several years to do the work, and we took some time to publish it, but here are the results. The proposition I think you all would understand is that older people are considered to be in a very vulnerable position when they find their way into acute hospital setting. You know, some people make out that hospitals are dangerous places for older people. They're also dangerous places for younger people. Part of that's because only sick people end up in hospital. They're already in danger. For many people, it's dangerous to not go to hospital when you get sick. So the word danger can be used rather liberally in all of this. On the other hand, it's well known that adverse events are common and more common amongst older people in hospital. And there is some reasonable, even good evidence that good practice minimises the risk of these adverse events, and that monitoring processes and outcomes are essential to optimise the outcomes. And we set about a process to develop some quality measures to support a quality improvement and benchmarking idea in relation to older people who find their way into hospital. So this was a three-phase project. First, we started with a conceptualisation. We used expert panels to consider what kind of outcomes would be of concern for older people, for example, the incidence of delirium or functional decline, that kind of thing. That involved reviewing the literature and creation of some ideas, some concepts about quality measures. These measures were kind of crystallised by this expert group and the study team, and then we set about a field study to examine a number of aspects of the performance of these quality measures. That would include, for example, ease of use, feasibility of actually scoring them, time taken to do it, and so forth, and also what the frequency distributions, in other words, how common are these events and to what extent did they vary amongst hospitals. And the third piece, I'll go into a little bit more detail in a second about each of these elements, and then there was an analysis phase, and again, groups of experts were brought together to seek consensus around which measures would be most appropriate for use in hospital. So I'll just provide a little more detail quickly about these various phases. So the development phase, what kind of outcomes matter? What does the literature say about the evidence that these outcomes can be influenced by the provider, the hospital that is? And we had two expert groups. One was more general health measures in regard to older people in hospital. Another one group studied cognitive health, specifically dementia and delirium predominantly. And we developed a draft set of QIs based on the data elements that are in what is now called the Acute Care Comprehensive Geriatric Assessment data set that's designed to support comprehensive geriatric assessment in hospital settings. So the field study involved 9 hospitals in Victoria and Queensland. The target population was all older patients admitted to hospital who are aged 70 years and older into medical wards and who were expected to stay at least 48 hours in the hospital, enabling sufficient time to do the data collection and discharge assessments. And so the interRAI ACCGA was scored by specifically trained nurses at 24 hours from admission and at discharge from the hospital. And there was a follow-up telephone call at 28 days to identify the person's status, whether they were still at home, whether they died, and how well they were functioning. And the analysis phase worked out the trigger rates for each of the QIs for each of the 9 hospitals. The results of the frequency distributions, the distributions and so forth were examined by the panel, also other qualitative feedback from the persons who were collecting the measures was all taken into account, and a consensus process was set up to work out what the experts thought might be the best QIs amongst those that we scored. So the RAND UCLA consensus methodology was applied to get secure agreement. So we, amongst the 9 hospitals, we recruited 643 older people. Just some idea of who they were is presented here. About half of them were males. About nearly 90% came from a community setting. 22% had been in hospital in the previous 90 days from recollection. About a quarter had cognitive impairment. That's pretty consistent with other studies of older people in hospital. The length of stay, median was 6 days, and the interquartile range was 3 to 11 days. About 20% were readmitted within 28 days of discharge, and about 8% died within the 28-day period. About half of those died in hospital. And the number that were transferred newly to an aged care facility was about 5% out of that sample. But perhaps the headline finding was that about 35%, 34% had at least one adverse outcome, that being falls, pressure injury, ADL decline, or delirium. So it's true that these kind of adverse outcomes are quite common amongst a general sample of older people in hospital. So I'm just going to list the quality indicators that were agreed to be appropriate at the end of the project, and then I'll just show you some of the distributions that we found in the study. So the first is the application of a new bladder catheter amongst females, often thought to be unnecessary in many cases. You'll have your thoughts about that. Men who get a new catheter often need it. You know, it's clearly indicated because of prostate problems. So that was the discussion about men and women. Presence of delirium, residual delirium symptoms at discharge. Each one of these needs a 20-minute discussion to decide why we came to these conclusions, by the way. Those that had worsened cognitive function at discharge compared to pre-morbid, that is their CPS score, as for those of you who know it, was higher at discharge from hospital than it was before they became unwell. And similarly, was their mobility at discharge worse than it was prior to admission to hospital, before they became sick, in other words. Those people that declined in self-care ability as a result of their acute illness should recover to their pre-morbid function. So failure to recover was a further quality measure. Persons that developed new pain as a result of the acute illness, for whom it wasn't resolved by discharge, is another measure. Those who developed a new pressure ulcer or developed a worsening pressure ulcer during hospital were considered as a group of people that had an adverse outcome. Having a fall during the hospital stay, staying in hospital for an extended period whilst not waiting for long-term care, and a new discharge to higher level of care, based on the idea that hospitals can influence return home versus placement in care rates. And I think that's the panel of indicators that we published. Here are the distributions ranked according to their frequency. So skin problems, pressure injury, relatively low frequency in this sample, up to failure to improve in self-care was more common up on the right-hand side of this. So you can see there's quite a bit of variation amongst hospitals, particularly in regard to some of these measures here, like length of stay and delirium, cognitive loss. Variation in the mind of a quality indicator developer says there's got to be something either to explain this in terms of risk adjustment, or the hospitals are performing differently in terms of these kind of measures. So that's kind of where the results lay across these various domains. this needs more work. No one's going to argue about that. It's a starting point for development of these kind of measures for acute care. So a task that we haven't, well, we've done in part, but we now have the interRAI acute care assessment, which if applied, and it's starting to happen in New Zealand, if it's applied to all residents, all people that come into hospital, so older people would need to have the data elements that score these indicators built into the AC. A lot of them are there, but not all. The second thing is to develop the indicators more, we do need a lot of data. So that means lots of interRAI acute care assessments need to be done with admission and discharge assessments and some level of pre-morbid data to score these indicators, but also to get some sense of what the real frequency distributions are, and also to provide the opportunity for risk adjustment. As no doubt there will be need for risk adjustment, and you need big numbers to do that. So, and then there's all work to do on many of these. What I mean by external validation is demonstrating that you can actually make a change. So if you present a quality indicator to an audience, a group of hospitals, and then you see changes in behaviour, changes in process, and then you see movement in the indicators, that suggests that these are valid indicators. If nothing happens in spite of major efforts, then that's not a good indication of a very good quality indicator. Also, very nice to have big, large-scale randomised controlled trials to see if interventions make a difference to these measures as well. And you'd all be aware, for example, the difficulty in trying to reduce falls rates in hospitals. Even though we have, an indicator for falls, you do need to know that interventions can change that falls rate, and the evidence for that is challenging. So that's where we're at with that work. There's another generation of work to be done, and that's going to require big scale implementations in order to make that possible. We're out of time, just on time perhaps. Does anyone want to ask a question or make comment about this? Folks from New Zealand are obviously ready to implement all of this and provide us with the data in our dreams. That'll be good. We're looking for others to do this as well, of course.
Look forward to providing the data. Hopefully we'll get enough for you, Len.
Yes, it's exciting times with you doing this work. Obviously, we're looking elsewhere to get others to do some more of this work as well. Lots of discussion we can have about putting standardised data into the acute care setting. It's a multi-dimensional problem that would take an hour to talk about, but we all know that challenge. Okay, well, thank you for coming along today. We'll stop there. Others have got things to do, I think. But you can see there's some interesting things happening in Australia, both in terms of opportunities for implementation, but also we're still pressing on with our research efforts, and so hopefully you found that interesting. I don't think we're convening this group again until the new year, but we should have some interesting things to talk about probably after the February meetings with the interRAI folks. Okay, thanks for coming. Talk soon. Bye-bye.
For those of you listening to this conversation who may have further interests in interRAI systems, please visit our website, interRAI-au.org.